Moving right along with this concept of physical activity, health, exercise prescription, minimum equivalencies, blah, 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 right? How do we actually know that we're improving cardiorespiratory fitness? What is our primary marker of cardiorespiratory fitness? It's going to be VO2 max, right? VO2 max, maximal volume of oxygen that can be consumed and utilized. In general, our relative risk of immediate death, our relative risk of premature mortality, morbidity, all that, decreases as our VO2 max increases. So as we become more cardiorespiratorily, as we get greater cardiorespiratory fitness, there it is, found it, we're going to actually have significant improvements in health, or significant improvements in longevity, if you will. Well, that's a little bit convoluted, because what we know is that higher VO2 max is essentially associated with reduced all-cause mortality or all-cause risk of death. Now, generally, the people that are going to have higher VO2 max are also going to be undertaking less risky behavior. They're not going to be smoking. They're going to have less disease. They're going to have better nutrition. They're going to take health a little bit more serious. So there's a lot of confounding variables going on here. But in general, the more fit you are, the less likely you are to die too young, or die early, or die unexpectedly. What's really kind of interesting here is that it's not the high levels of fitness that are going to get the biggest improvements here. So let's say I have a VO2 max of 60, which is really, really good, right? It's pretty good. And I go up to a VO2 max of 70. I'm not going to get that big of a health benefit. But if I go from a VO2 max of 20 to 25, I'm going to get a significant improvement in health benefit. So it's actually that lower end, that left-hand side of that U-shaped curve, that's going to actually get the biggest health bump, the biggest health benefit based on VO2 max. So for every one MET improvement, for every one 3.5 ml per kg per minute improvement in your VO2 max, your relative risk of early death or premature mortality decreases by 13%. So you get significantly better lifespan and health span by improving your cardiorespiratory fitness. So if VO2 max is such an awesome standard, how are we going to assess it? Well, ideally, we're going to use one of those graded exercise tests, or ramp tests, or step tests that we've talked about as we were talking about endurance training, as we're talking about like endurance exercise activities, and how they reflect physical activity and exercise physiology and the gas response and blah, blah, blah. Ideally, we're going to use one of those graded exercise tests, or a non-steady state test. So let's say we're assessing VO2 max directly. What we're going to see is we're going to see the highest values for VO2 max coming from running, incline walking, and then cycling. Rowing is in there as well. And why is it that you would expect to see that? Like, let's think about that. Our VO2 max is going to be the determinant of our cardiac output and our AVO2 difference. In order to maximize our cardiac output and maximize our AVO2 difference, what we need to do is increase the amount of muscle mass that's going to be working. So something like running is going to have significantly more muscle mass involvement than something like cycling. Cycling is going to be predominantly lower body, large muscle groups, but lower body, whereas running is going to get the arms, get the legs, get everything. Rowing is going to be the same, right? It gets the arms, get the legs, get everything. So you're going to get relatively high VO2 maxes the more muscle mass you're involving. So that's why cycling, you're going to see lower VO2 maxes. Plus, most Americans don't hop on bikes. We walk everywhere, whereas Europe, it's kind of opposite. You'll see that sometimes. Just a tidbit of information for you. As we're kind of continuing on this topic, something that I want you guys to be paying attention to is whether or not something is a true VO2 max or if it's just a VO2 peak. Remember, VO2 max is required to have a plateau. We must have that plateau. As we increase a work rate, VO2 max will not see a change. So that volume of oxygen being consumed and utilized does not change as we increase work rate. So we have plateaued. But if someone stops early on a test, or let's say that we don't see that clear plateauing, but they still can't continue exercise, that's going to technically be a VO2 peak, not a VO2 max. We can technically determine a VO2 max without a plateau based on a couple of different things. So we need to have an RER, or respiratory exchange ratio, or a ratio of carbon dioxide to oxygen. Remember, we talked about that, of greater than 1.15. We need a heart rate max greater than 85%. We need a very specific lactate threshold to be achieved. There's a lot of different things that go into a true VO2 max. But assessing and quantitating that true VO2 max is going to require expensive lab equipment. It's going to require a gas exchange analyzer. So we're actually going to be measuring the oxygen and CO2 that's going in and coming out. We're going to be measuring heart rate. We're going to be measuring everything. So that's going to be a very expensive test. It's going to be very involved, and it's going to require quite a bit. So it's not something that we're going to be able to do on your grandmother Jane as she's trying to learn how to walk again after breaking a hip. But what we can do is we can estimate our VO2 max using sub-maximal exercise testing. So rather than pushing a person to the limit, rather than having the exercise masks and having these gas masks that are going to be analyzing exchanges in oxygen and CO2, we can actually estimate based off of heart rate. So if you guys remember that there is a near linear relationship between heart rate and VO2 max, right? As we increase in intensity, our heart rate is going to continue to increase, and thus our VO2 max is going to continue to increase. So how you do a sub-max test generally is you're going to track heart rate across an increase in intensity, and you continually track that heart rate until they reach a 70 to 85% of their heart rate max, which remember is 220 minus their age. Once you hit that 70 to 85% max, you basically draw a work rate line down, and we can start to extrapolate about what they would be if we worked up to 100%. You'll learn about this in exercise testing and prescription, but what I want you to know is that this is a true estimate. It's not quantitative, and it is an estimated VO2 max, not a real VO2 max. Now, a big problem with this concept of an indirect or an estimated VO2 max is that we're basically doing a couple of different things. One, we know that the heart rate can only increase so much, right? We know that we can only increase heart rate so much before it plateaus. So we're automatically introducing a level of variability or a level of confusion into this equation or into this concept. The other thing is what happens if the individual's max heart rate isn't actually their 220 minus age. Like that is just an average of what would be like the world's population, right? Like 220 minus their age is not individualized. It doesn't work for every single person. So if we introduce a flawed concept on the front end, what is that going to do for our estimate of the true individual's VO2 max? Well, it's going to obfuscate it. It's going to confuse it. It's going to make it a little bit less clear and a little bit more murky. So it's not going to be it's not going to be a super accurate way of estimating VO2 or assessing VO2. But what we can do is we can use that VO2 estimate to track changes over time. What we can do is we can actually continually assess or repeatedly assess or track changes across time by using those indirect measures or using those estimates of VO2. So it allows us to basically use a sub-gold standard method accurately and repeatably. And what it does is it allows us to do something to track fitness levels when we don't have access to high levels of equipment. So how do we know when someone's ready to actually exercise? Like if you guys are like me, you probably have quite a few friends, family members, whatever, that would love to start exercising, but you look at them and you're like, right? Like give it all the different stink faces that you can possibly come up with, and you're like, right? So one of the very first things that you need to do is you need to make sure that you complete a health status questionnaire. You need to make sure that you assess the individual's ability to actually start or undertake an exercise regimen. So you can do something like a physical activity readiness questionnaire, which is a PAR-Q, super, super common, very good screening tool. But then you can also employ the ACSM's guidelines for exercise testing and prescription. You'll learn about those in Ms. Alvarez's class. And kind of what the algorithm looks like to determine whether or not someone's ready to exercise or not. But essentially what it does is it gives us a level of clearance or a level of of satisfaction, knowing that the individual might be ready for exercise. And if they're not ready for exercise, whether or not they need to have a physician present or they need to have physician clearance before they can start their exercise routine. So essentially this is like a CYA thing. You need to make sure that you screen for pre-participation and pre-screen for assessments and prescription. All right. After you get through the screening, we need to come up with a general progression protocol. So we're going to have to do baseline VO2 max assessments, probably going to use that sub-max or that VO2 max estimating technique to determine where an individual is at and get a true baseline. And then we want to come up with a way that we can actually stair step or progress or overload the individual to eventually achieve their physical activity or fitness goals. In general, what we want to use for our progression is we want to use relative intensity to guide that effort. We want to use this concept of how much above rest are they doing, like these kind of subjective feelings. We can use something like the Borg scale, which is a 6 to 20, which is going to give us an overall estimate of how hard an individual is working. And we want to transition from light exercise to moderate exercise to vigorous exercise. Remember, you get benefit from light exercise, and you get some of the biggest benefits the earlier you start exercising and when you start improving fitness earlier. But you can get away with doing less activity, or you can get more benefits the higher you go on the intensity scale. So our goal is to essentially progress an individual up in intensity so that we can improve their physical fitness and improve their efficiency of their time as well. Before we begin to actually increase intensity on an individual, what we want to do is we want to increase their minutes per day first. So rather than basically killing someone with higher levels of intensity and only working out for 10 minutes at a time, we want to progress that volume based on the duration first, and then we can increase the intensity once we get to a kind of like a happy Goldilocks phase here. Whatever you do, don't progress too fast with the exercise progressions. You can actually hurt someone if you move too fast. It's almost better to move a little bit too slow than to move too fast. So if we're going to be increasing the duration of exercise, the number of minutes per week that they're getting, we can do that based on frequency or duration. So we can actually, the goal for completing moderate intensity exercise per week, which again, remember, if we're starting somewhere, we're starting light, then moderate, then vigorous. The goal, if it's moderate intensity exercise, is about 5 days per week or more. We can drop that volume back. We can drop that frequency back to 3 days or more per week if it's vigorous, because you kind of want to give them a couple of days to recover in between vigorous exercise bouts. You can see improvements with as low as 2 days per week of exercise, but you got to be working out pretty high because you got to be able to achieve those minute goals of that 75 to 150 minutes. So it's not going to be the easiest thing to do. So generally, the more frequent the exercise bout, the better it will be for the exercise prescription. The easier the exercise prescription gets. Now, with intensity, if we're trying to improve cardiorespiratory fitness, which cardiorespiratory fitness is going to be the one that's really linked to that premature mortality morbidity decrease, we want to make sure that we're working in that 60 to 80% range for VO2 max. So we got to determine a VO2 max on the onset of exercise, or determine a baseline. And then we want to be working those individuals at intensity in that 60 to 80% range. You can get away with lower, the lower the fitness scale is. In some individuals, you might have to go higher because they might be more fit individuals. So you're going to have to be able to scale this level of 60 to 80%. You can scale high, you can scale low based on the patient or the client that you're going to be working with. So if we're not using lab techniques to actually be assessing VO2 max, we're going to have to be using these kind of field-based or rough measures of intensity or percent of VO2 max. And again, we're going to be using heart rate here. So what we'll do is we'll actually calculate heart rate zones. Rather than insult your intelligence and read through these next 4 or 5 bullet points, I want you to read through those on your own, use the book, and get practice calculating target heart rate zones, because they will be on your exam, I promise you, and it'll be something that you deal with in exercise testing and prescription all the time. One of the best ways that we can actually measure intensity if we're not going to be using heart rate is the Borg scale. And what the Borg scale is essentially it's a range from 6 to 20, 6 being pure rest, 20 being the hardest physical activity you've ever done in your life. The higher that number is, the higher the intensity is that an individual is working at. Technically, the Borg scale should line up with their heart rate. So at 6, their heart rate should be about 60, or a resting heart rate. In 20, their heart rate should be about 200, which would be a very high heart rate. So generally, an individual should be working within that 6 to 20 range. And if we're going off of 60 to 80% of their VO2 max, you would assume a max heart rate is being achieved, and then we can calculate target heart rate zones and Borg scale zones off of that target heart rate and that goal of the Borg standard with 6 to 20. If that's confusing, let me know. We can clarify it in class. Now, our other T, or one of our T's in the FIT principle, is going to be time. We want to make sure that our time is going to be accurately programmed with our intensity. If our intensity is high, our time needs to be low. If our intensity is low, our time needs to be higher. So it's going to be inversely related. We cannot exercise at high intensities for long times. It's not necessarily possible. So the individuals that are trying to get cardiorespiratory fitness goals but not wanting to work at high intensities, or they're unable to work at high intensities because of some sort of deficiency or movement deficiency or a health-based issue, we're going to have to bump up their time. So they're going to have to spend longer durations of time being physically active in order to get those improvements in cardiorespiratory fitness. In general, we want to walk before we run. We want to start slow, and we want to increase the level of physical activity. We want to increase the frequency. We want to increase the duration. We want to increase the time. Doesn't make sense. We want to increase the frequency. We want to increase the duration. We want to increase the intensity. And as we progress through, we can actually start incorporating things like sport. We can start incorporating things on the right-hand side of that U-shaped curve to start and continue the improvement of cardiorespiratory fitness. Something that you also need to remember is that we need to be including resistance training and flexibility. Those two concepts alone go well beyond the scope of this chapter, and they have full textbooks devoted to them, so it's almost not fair to even mention them here. But we also want to make sure that any cardiorespiratory fitness that we're doing to improve health, we're also going to be lifting weights, and we're also going to be including flexibility-based activities. So guys, that's it. Exercise prescription is done. Next week, we're going to be talking about environmental phys. This is one of my favorite topics. It's where we kind of get to see some of the deviations in normal physiology as we change where we are in the world. It's a really, really cool concept. And I hope you guys like this lecture, and I hope you guys like the next one as well.